Hi everyone, this is Mehak. I am a student of second year DPT. Today we are going to talk about dermatomes and myotomes. I'll try my best to make this topic as easy for you. So let's get started. So these are my contents. What are dermatomes? And we will talk about how a spinal nerve is formed, map of dermatomes and its location in body. Where do we test each dermatome? And what is the clinical significance of dermatomes? Or why are they so important? What is a myotome? Myotome testing. What is the clinical significance or importance of myotomes? And finally, what is the difference between myotomes and dermatomes? Have you ever thought how you manage to experience so many sensations within a couple of minutes? It's all because of the largest organ of our body, that is, skin. Our surface of skin is divided into thin segments or sections, and these sections of skin are supplied by a particular nerve. So, what are dermatomes? The term dermatome is a combination of two ancient Greek words, derma, which means skin, and tome, which means thin segment. Dermatomes are names given to particular surface areas of our body. In our body, there are total 29 dermatomes, in which 7 are cervical, 12 thoracic, 5 lumbar, and 5 sacral. Remember, when we are talking about spinal cord, there are spinal nerves, which are branching out of spinal cord. As we all know that spinal nerves have both sensory and motor fibers because they are mixed nerves. Sensory fibers innervate these areas of skin and receives sensory information which is coming from these parts of body. Now look at the first picture. This is a cross-sectional area of one of the somites of this developing embryo. There are basically three parts of somite: D, M and S. D means dermatome, M means myotome and S means sclerotome. So, dermatomes will migrate out and they will form dermis or skin. So why am I telling you all this? It's because there is one more definition of dermatome which I want you to understand. That is, it is a part of somite that gives rise to dermis. Between these somites, you can see a circular tube, that is neural tube. This neural tube will become spinal cord eventually. Now look at the second picture. You can see that all the areas of the C6 dermatome, all sensory neurons of this area of skin go to the same spinal cord level. So, if we test this specific area of skin, so we can actually test a specific spinal nerve level. Let's talk about how spinal nerve is formed. Each spinal nerve is formed when our ventral or anterior root and dorsal or posterior root meet, and then they extend into our peripheral nervous system. Dermatomes supply bilateral regions of skin. It means area of skin supplied by one pair of nerve. Remember, ventral root will carry motor response to peripheral nervous system and sensory root will carry sensory information into the central nervous system, which is our brain and spinal cord. When ventral root and dorsal root means posterior root meet, it forms spinal nerve. Spinal nerve is a mixed nerve, as I told you earlier. Mixed nerve means it carries both sensory and motor information. Spinal nerve gives two branches. One is dorsal ramus and another is ventral ramus. Dorsal ramus will come out of our spinal nerve and supply skin and muscles of our posterior body wall. Ventral ramus will supply skin and muscles of our lateral and anterior body wall. The spinal nerves are basically classified into 5 groups. They are classified according to the region of the spine from which they exit. The 5 groups are cervical nerves, thoracic nerves, lumbar nerves, sacral nerves, and a coccygeal nerve pair. So, cervical nerves. These exit from the neck region of our body and are labeled as C1 to C8. Thoracic nerves. They exit from the torso region of our body and are labeled as T1 to T12. Lumbar nerves. They exit from the lower back region of our body and are labeled as L1 to L5. Sacral nerves. These exit from the base of the spine and are labeled as S1 to S5. And a coccygeal nerve pair. These exit from the tailbone or the coccyx bone of our body. In humans, the spinal cord begins at the occipital bone and it extends down to between the first and second lumbar vertebra where it ends. The human body is basically divided into certain regions: the neck region or the cervical region, then thorax region, then lumbar region or abdominal region, and finally the pelvic region. Okay, so the vertebral bones which are present in cervical or neck region are called as cervical vertebra, and spinal nerves which will emerge out from this area will be called as cervical nerves. So basically there are total 7 cervical vertebra, but one important thing that you need to remember here is that there are total 8 spinal nerves. The C1 nerve passes above C1 vertebra and the C2 nerve will pass above C2 vertebra. All cervical spinal nerves passes above corresponding level to their vertebra, but C8 nerve passes below C7 vertebra, or you can say it as above T1 vertebra, as there is no C8 vertebra because we have only 7 vertebrae in cervical region. Now thoracic region. There are total 12 thoracic vertebra and the nerves which emerge out from here will be called as thoracic nerves. Then lumbar region. There are 5 lumbar vertebra and spinal nerves which emerges through these areas are called as lumbar nerves. Then pelvic region. There is one sacrum and coccyx bone which is present in our pelvic region. So there is sacral nerve and coccygeal nerve. As sacrum is a single bone, but basically it is a fusion of 5 bones. So 5 pairs of sacral nerves emerges from this area. And coccyx bone is formed by a fusion of 4 separate bones. There is only one pair of single coccyx nerve which emerges out from here. Segmental organization. As all these nerves emerge as segments, spinal cord is also present in segments. Due to the formation of skin, dermatomes maps may vary. Can you see these red dots here? Sensory neurons from skin, indicated by red dot, travel to only one spinal cord nerve level. For example, if you are testing dermatome L3 level, here are the spinal cord levels of L2, L3 and L4. As dermatomes overlap each other sometimes, there is overlap between supra and infra-adjacent dermatomes. But if you take a look at this red dot, there is no sensory overlap with L2 and L4. It's consistent. Sensory neurons at the red dot go to only the L3 spinal cord nerve level. Now, let's discuss the dermatomes of the head and the neck region. As we all know that there are 12 pairs of cranial nerves. Cranial means brain, so these nerves originate from the brain instead of spinal cord, which are called as spinal nerves, which we discussed earlier. The fifth cranial nerve is called as trigeminal nerve. It is named so because it has three main sensory areas of distribution. There are three main branches known as ophthalmic branch, maxillary branch, and mandibular branch. These branches exit from three separate foramens. Ophthalmic branch exits from superior orbital fissure. Maxillary branch exits from foramen rotundum. Mandibular branch exits from foramen ovale. The areas that these nerves supply are called ophthalmic area, maxillary area, and mandibular area. Ophthalmic branch supplies forehead, nose, conjunctiva, and cornea of the eyes. Maxillary branch supplies skin over the maxilla, upper jaw, nostrils, inferior nasal mucosa. It also supplies palate, superior part of the throat, and most importantly, you have to remember it also supplies maxillary, ethmoid, and sphenoid sinuses. Mandibular branch supplies skin over the mandible, as the name indicates, lower jaw, inferior teeth and gums, and angle of the jaw and skin in front of the ear. Starting with C2. The C2 covers the posterior aspect of the head in the C shape, and it goes from one ear posteriorly to the other ear. I repeat, the C2 covers the posterior aspect of the head in the C shape, and it goes from one ear posteriorly to the other ear. Now, let's discuss the dermatomes of the upper limb one by one. Dermatomes of the upper limb. C3. C3 is in the ring from lower half of the anterior neck round to the posterior neck and coming back to the anterior neck. Let's do it once more time. C3 is in the ring from lower half of the anterior neck round to the posterior neck and coming back to the anterior neck. C4. C4 is from the medial clavicle directly across the acromioclavicular joint. I repeat, C4 is from the medial clavicle directly across the acromioclavicular joint. C5. The way you can always remember your C5 is by 1/3 to 1/3 rule. 1/3 down the lateral humerus, going down to the lateral side of the arm to 1/3 down the radial side of the forearm. Let's do it once more. 1/3 down the lateral humerus, going down to the lateral side of the arm to 1/3 down the lateral side of the forearm. Humerus is the bone present in the arm and radius is the bone present on the lateral side of the forearm. C6. C6 goes in the direct line from the anterior shoulder down to the base of the thumb and then into the thumb. Let's do it once more. C6 goes in the direct line from the anterior shoulder down to the base of the thumb and then into the thumb. C7. C7 is a smaller dermatomal region from the center of the palm to the second, third, and fourth digits anteriorly as well as posteriorly. Once more, C7 is a smaller dermatomal region from the center of the palm to the second, third, and fourth digits anteriorly as well as posteriorly. T1. T1 is 2/3 to 2/3. If you remember, I told you C5 is 1/3 to 1/3. But T1 is 2/3 to 2/3. T1 is 2/3 down to the medial aspect of the humerus, running across the ulnar side of the forearm, 2/3 to the way down. Once more, T1 is 2/3 down to the medial aspect of the humerus, running across the ulnar side of the forearm, 2/3 to the way down. T2 basically supplies anteriorly and posteriorly at the level of the upper axilla. I repeat, anteriorly and posteriorly at the level of the upper axilla and medial and upper aspect of the arm. Now, let's discuss the dermatomes of thorax and abdomen region. On torso, dermatomes are regularly shaped and they overlap each other. But on limbs, dermatomes are irregularly shaped and they do not overlap. They do not overlap means it is the only nerve that's supplying that area. So that is why on torso it is difficult to assess them. Now let's discuss few important dermatomes of torso that you should learn. T1 provides sensory information from medial forearm. Once more, T1 provides sensory information from medial forearm and T2 provides from apex of the axilla and armpit. The rest of the thoracic dermatomes are easy and they are arranged in order down the trunk. Some important landmarks that you should know are T4 nipples, T6 xiphoid process, T10 umbilicus and T12 pubis. So, let's discuss the dermatomes of the lower limb. L1 posteriorly includes the skin lateral to L1 vertebra. I repeat, posteriorly it includes the skin lateral to L1 vertebra and wraps anteriorly to the groin and pelvic girdle area superior to the inguinal canal. Wraps anteriorly to the groin and pelvic girdle area superior to the inguinal canal. L2. L2 dermatome just starts distally to the greater trochanter of the femur and runs 4/5 to the way down to lateral thigh, down the lateral femur. Once more, L2 dermatome just starts distally to the greater trochanter and runs 4/5 to the way down to lateral thigh, down the lateral femur. Remember, femur is the bone present in the thigh. L3. Halfway down the medial aspect of femur, running along the medial side of the femur, distal to the medial tibial condyle. Once more, halfway down the medial aspect of femur running along the medial side of the femur, distal to the medial tibial condyle. L4. A quarter of the way down the medial aspect of the tibia underneath the medial malleolus, medial arch, and down to the sole of the foot at the first digit. Once more, a quarter of the way down the medial aspect of the tibia underneath the medial malleolus, medial arch, and down to the sole of the foot at the first digit. L5. Quarter of the way down to the lateral aspect of the fibula and then into the diagonal line with the big toe on the dorsum of the foot. Once more, quarter of the way down of the lateral aspect of fibula and then into the diagonal line with the big toe on the dorsum of the foot. Remember, tibia and fibula are the bones present in the leg. S1. S1 supplies from the lateral malleolus, lateral side of the foot and fifth digit towards the lateral side of the fifth toe. Once more, L1 from the lateral malleolus, lateral side of the foot and fifth digit towards the lateral side of the fifth toe. S2 extends from the buttocks to the posteromedial aspect of the thigh, popliteal region and leg. Once more, from the buttocks to the posteromedial aspect of the thigh, popliteal region and leg. Basically, whole of the posterior aspect of thigh, knee and leg is supplied by S2 and anteriorly the penis and scrotum is supplied by S2. S3 supplies posteriorly. It includes the medial aspect of buttocks. Posteriorly, it supplies the medial aspect of buttocks and perineal area, and anteriorly, it supplies the penis and the scrotum. Once more, anteriorly, it supplies the penis and the scrotum. S4 supplies the perineal area and genitals. Once more, perineal area and genitals. S5 supplies the perineal area and skin of and adjacent to the anus. Once more, perineal area and skin of and adjacent to the anus. So basically, this is the list of the location of the red dots. As I told you earlier that red dots are consistent and sensory neurons from skin which is indicated by these red dots, they go to only one spinal cord level. So it's very important to learn about them so you can know the correct location of each dermatome. So what is the clinical significance of dermatomes? Of course, it will help you localize problems in different areas of spine. Dermatomes are important because they can help to assess and diagnose a variety of conditions. For instance, symptoms that occur along a specific dermatome may indicate a problem with a specific nerve root in the spine. Dermatomes have clinical significance, especially in the diagnosis of certain diseases. Symptoms that follow a dermatome such as pain or a rash may indicate a pathology that involves the related nerve root. Examples include dysfunction of the spine or a viral infection. For example, dermatomes are easily outlined by things called shingles. Shingles is one of the only diseases that causes a rash in a dermatomal pattern. We will discuss about shingles in the next slide. Shingles is a painful skin condition in adults caused by the varicella zoster virus. The rash of shingles is almost always restricted to a specific dermatome, such as on the chest, leg, or arm. So we can follow this dermatomal pattern and we can pinpoint exactly which spinal nerve has been infected. As I told you earlier, shingles is because of the virus that affects our spinal nerves. You can see in this picture that in this patient, one of the dermatomes in the arm is affected, restricting the rash to the length of the back of the arm. Now, we will talk about myotomes. What are myotomes and why are they important? So, this term myotome is basically based on the combination of two ancient Greek words, myo, which means muscle, and tome, which means cutting or thin segment. So, myotome literally means thin segment or section of a muscle. But clinically, we say myotomes is a group of muscles innervated by a single spinal cord nerve level. As I told you earlier, spinal nerves have both motor fibers and sensory fibers. The motor fibers innervate certain muscles. A group of muscles innervated by the motor fibers of a single nerve root is known as a myotome. So now let's take a look at the lateral view of the developing embryo. This is a cross-sectional area of one of the somites of the developing embryo. As we discussed earlier, I told you that basically there are three parts of somite: dermatome, myotome, and sclerotome. So myotomes are that which will give rise to skeletal muscles. Myotomes migrate out of your body at every segmental level. Myotomes are a group of muscles innervated by a single spinal cord nerve level. But also, myotomes are a part of somite that forms muscles. So these myotomes migrate out and form skeletal muscles, and at every level there is an associated spinal cord nerve level that has a motor neuron that sent its axons to innervate those group of muscles. So basically, motor neurons carry signals from the central nervous system to the other parts of your muscle, skin, and glands of your body. Remember, sensory neurons bring signals into the central nervous system, and motor neurons carry signals out of the central nervous system. So let me give you one simple example. I hope it will be clear then. Suppose your phone rings. The sensory neurons in your ear will gather this sound information and send it to central nervous system. Your brain then will interpret this information and identify the sound as the phone ringing. This information is then sent to your motor neurons. The motor neurons send nerve impulses to your muscles, which will allow you to answer the phone call. If you test a specific movement, you can test a specific spinal cord and spinal nerve level. So there is one somite at that spinal cord level. It gives rise to myotome, and myotomes are a group of muscles innervated by a single spinal cord nerve level, and these muscles perform a specific action. So what we see is if you test a specific movement, you can test a specific spinal cord or spinal nerve level. Now take a look at the first picture. C5 myotome. C5 myotome, which is shoulder abduction. Abduction in Latin means take away. It means the movement of a limb away from the midline of the body. We have a motor neuron which goes out from C5 vertebra and is responsible for shoulder abduction or abduction of glenohumeral joint or shoulder joint. Now take a look at the second picture. C6 myotome is elbow flexion, which means bend the elbow. C6 nerve goes to muscles that will bend the elbow or perform elbow flexion. Flexion refers to the movement that reduces the angle between two body parts. Now look at the first picture. C7 myotome is elbow extension, which means to straighten the elbow. Extension refers to the movement which increases the angle between two body parts. So there's C7 vertebra and then the motor neuron goes out from C7 vertebra and goes to triceps muscles. So elbow extension is associated with C7 myotome in spinal cord level. Now look at the second picture. C8 myotome is finger flexion or bending of the fingers. So there's C7 vertebra, but C8 spinal nerve courses below the C7 vertebra and it goes to those group of muscles that perform finger flexion or bend the fingers. T1 myotome is finger abduction, which means spread fingers apart. Abduction is a movement of a limb away from the midline of the body, as I told you earlier. So there is T1 vertebra and T1 spinal nerve courses underneath T1 vertebra and it goes to intrinsic muscles of hand to perform finger abduction. L2 myotome is hip flexion, which is lifting the knee off the ground. There is L2 spinal cord level and the L2 spinal nerve goes to hip flexors and it lifts the knee off the ground or performs flexion of the hip joint. L3 myotome is hip adduction, which means squeezing thighs together. Adduction is the movement of a body part towards the body's midline. So there is L3 vertebra and L3 spinal nerve goes to adductor muscles, medial compartment of the thigh and performs hip adduction. L4 myotome is knee extension, which means straightening the knee. So extension refers to the movement which increases the angle between two body parts, as discussed earlier. So L4 spinal nerve goes to quadriceps muscles and performs knee extension or straightening of the knee. L5 myotome is dorsiflexion, which means lifting foot off the ground. Dorsiflexion is the movement of the foot upwards so that the foot is closer to the shin bone. In dorsiflexion, the foot should be raised upward between 10 to 30 degrees. So there is L5 vertebra and L5 spinal nerve which goes to anterior crus muscles of your leg, which performs dorsiflexion, which is lifting the foot off the ground. S1 myotome is plantar flexion, which means standing on tip of your toes. Plantar flexion refers to the movement of the foot when it is bent at the ankle away from the body. So there is S1 vertebra and the motor neuron goes to posterior calf muscles of your leg, which performs plantar flexion, which means standing on tip of your toes. Now, if we look at the muscles of the anterior abdominal wall and all the intercostal muscles which has an associated spinal cord level T12 to L1. So T12 to L1 myotomes are difficult to assess because their associated movements are harder to test compared to the movements of the limb. On torso, dermatomes are regularly shaped and overlap, but on limbs, areas innervated are irregularly shaped and do not overlap. It means that it is the only nerve that's supplying that area, but on torso, it's difficult to assess. So, let's discuss few important dermatomes of torso that you should learn. T1 provides sensory info from medial forearm and T2 provides from apex of the axilla and armpit. The rest of the thoracic dermatomes are easy and are arranged in order down the trunk. Some important landmarks that you should know are T4, that is nipples. So, why do we need to do myotome testing? Basically, if your patient reports you with upper limb or lower limb weakness, so you can use myotome testing to check if it is because of neurological deficit. So myotomes are tested by asking patients to perform different movements which are associated with different spinal nerves. For example, C6 myotome is mainly responsible for elbow flexion, right? So when we are testing myotomes, we will ask patient to perform different movements and also push against the therapist resistance to test different muscles. The clinician performs the test with resisted isometric contractions and the joint that is being tested should be at resting position. Muscle contractions should be held for at least 5 seconds. This is very important. And this will help you to pinpoint if specific spinal nerves are lesioned, diseased, or injured if the patient is unable to perform these movements. So, what is the clinical significance of myotomes or why is it so important to learn about them? The testing of myotomes basically provides the clinician with information about the level in the spine where a lesion may be present. During testing, the clinician looks for muscle weakness of a particular group of muscles, like if some nerve is supplying muscle and if that muscle is not working properly. So I will get an idea that the nerve supply is not well here. Suppose we will ask the patient to perform all those movements associated with each myotome to check if the myotome that's supplying those muscles is working properly or not. And if the patient is unable to do those movements, it means that lesion is present or maybe the muscle can be weak or the single nerve that's supplying those muscles is not working properly. Results may indicate lesions to the spinal cord nerve root or intervertebral disc herniation that presses on the spinal nerve roots. So what is the difference between myotomes and dermatomes? The first basic difference is a dermatome refers to an area of skin innervated by the nerves from a single spinal root, but myotome refers to the group of muscles innervated by the nerves of a single spinal root. The second difference is dermatome is a region of the skin innervated by a single spinal nerve, but a myotome is a group of muscles innervated by a single spinal nerve. The third difference is dermatome consists of overlapping regions innervated by more than one spinal nerve, but myotomes are innervated by more than one spinal nerve. The fourth difference is dermatomes are responsible for the coordination of senses, but myotomes are responsible for the coordination of voluntary muscular movements. Thank you for watching my video. I hope you found this helpful.